Jordan, how do you say your last name?
Brookheis.
Brokeis.
Yep.
Okay, great.
Thanks.
Okay. All right. Well, it sounds like we are ready. So welcome everybody to the SSAT webinar. It looks like we have about 31 participants on the call now. So we're going to start. Um, so welcome to the high yield topics for the ABSITE 2026 Part 1 webinar. So tonight we're focusing on some core areas that consistently show up on the exam, including breast, colorectal, foregut and thoracic, and endocrine. Before we begin, I just want to make a plug for the society that put this together, which is SSAT, Society for Surgery of the Alimentary Tract. It's a great organization. Every year we go to the Digestive Disease Week conference in Chicago. It's a fantastic meeting. There's a lot of jam medicine folks there. I love being a part of SSAT. It's really just like it's not a huge community. It's just like a nice collegial organization. There's a podcast you can get involved in if you want. We do a lot of initiatives, mentorship, and there's a lot of funding for people to travel to conferences and sort of get involved. So, highly recommend looking up the SSAT website. It's one of the organizations I care a lot about and get a lot of enjoyment being a part of. So tonight we're talking about ABSITE. Very exciting. So to introduce myself, first I'll introduce myself and then the panelists, and then we'll begin. So my name is Connie. I am a colorectal fellow at Ochsner here in New Orleans. I'm moderating this session. I just finished residency at UAB. And our first speaker is going to be Dr. Mackenzie Abraham, who is currently a chief at UAB and will be covering breast. She is going to stay at UAB next year for breast fellowship. After that, we'll have Hillary Johnson from the University of Wisconsin covering colorectal, and she will be the colorectal fellow at the University of Chicago next year. Our third speaker, Dr. Mitchell Wan, is a PGY2 from Loma Linda University who is thinking of going into thoracic, and he will take us through high yield foregut and thoracic topics. And then to finish, we have Dr. Jordan Brokius, who is a recently minted endocrine surgery attending at University of Nebraska, and he's going to review key endocrine topics. Jordan, I know I just asked you how to say your last name, and I immediately forgot, and I'm so sorry about that.
All good. All good. Thanks.
I was like, I know you just told me, but it immediately escaped my brain. But this session is going to stay in our brains. We are going to try to focus on just sort of like general broad frameworks of topics and, obviously leave the details to studying at home, but hopefully this will be a useful webinar to give you a framework. So to start off, we'll have Mackenzie Abraham.
All right, let me share. So, okay, can you see? Yeah. Okay. All right, so I'm going to talk about breast. So we'll start with some anatomy. So to start with the borders of the breast, clavicle, inframammary fold, sternum, and mid-axillary line, fairly straightforward. Then the blood supply also, so you have the lateral thoracic artery, which you can see here coming off the axillary artery, and then also the internal thoracic artery that medially and laterally supply. Battson's plexus is something that's sometimes tested. This is a valveless venous plexus that drains into the spine, so that can be responsible for some of the direct hematogenous spread to the spine in breast cancer. Lymphatics, 97% drain to axillary lymphatics, but we also think about these internal mammary nodes that we'll look at on future slides. And then Cooper's ligaments are the suspensory ligaments of the breast, which give it structure and are responsible for some of the dimpling you might see in cancer diagnoses. So when looking specifically at the axilla, which is a little bit more challenging than the breast anatomy, so borders of the axilla. So superiorly, we know the axillary vein is there. Laterally, we have the latissimus muscle, latissimus dorsi. Anteriorly, if you're thinking about this in a 3D structure, you have the pectoralis major and minor behind it. Posteriorly, meaning like the deepest part of the axillary dissection, you have your subscapularis on the kind of right on your scapula there on the inside. And then medially, your serratus anterior and your chest wall or rib cage. Looking at the lymphatics in that area, so on the second picture, we have the level 1 nodes, which are lateral to your pec minor, way out here. Level 2 is immediately posterior to your pec minor, and level 3 is medial to pec minor. Let me minimize this. So in breast cancer, we take levels 1 and 2. But then sometimes in melanoma, if they test this, you'll take all 3 levels if they require an axillary dissection, which is becoming less common. And then Rotter's nodes, if tested, are specifically between the pec major and pec minor muscles. There we go. Okay, so nerves and their injuries. So the intercostobrachial nerve, this is a sensory nerve that supplies sensory sensation to the upper inner arm. This is the lateral cutaneous branch of the second intercostal nerve. This is the most common injured nerve. And luckily, it's not a very big deal. If it's injured, you get some paresthesias to that area. The thoracodorsal nerve supplies the latissimus muscle. So it's a motor nerve. This can lead to weak extension, adduction, and internal rotation. So bringing the arm in and turned in. This is luckily less common. The long thoracic nerve, which supplies the serratus, can cause the classic wing scapula that's frequently tested. And then the supply to the pec, this is sometimes confusing because the medial pectoral nerve supplies both major and minor, and the lateral only supplies major. So I just remember major has 2 nerves because it's bigger. Okay, so talking about breast infections, I'll go through this kind of quickly because I think it's a little bit lower yield. But mastitis, so this is basically inflammation or cellulitis of the breast. It can be associated with abscesses or not. It can be lactational or not. The most common path or organism you're going to find is Staph aureus, and this is true for both mastitis and for breast abscesses. Treatment is antibiotics, warm compresses. If they are lactational, you would continue breastfeeding would be the recommendation. There are very, very few questions that I think the answer is to discontinue breastfeeding. So typically I would choose that. If it does fail to improve, the important thing is to make sure you do a punch biopsy to rule out inflammatory breast cancer if they continue to have skin changes that are refractory to standard treatment. Same with abscesses. So typically, this is a fluid collection you'd see on an ultrasound or other imaging study. Treatment is typically needle aspiration. I think in other areas of the body, we tend to do an incision and drainage first, but in the breast, we tend to aspirate. In breastfeeding patients in particular, you want to avoid doing incision and drainage if possible because there's a risk of developing a milk fistula. But if they do need if they have an abscess that's not responding to an aspiration, they should still get an incision and drainage to treat the infection, as well as antibiotics, warm compresses, and to continue breastfeeding as well. And again, if it fails to improve, you need to rule out cancer or do biopsy. Duct ectasia, which is also known as periductal mastitis. So this is associated with non-cyclical breast pain, erythema. You can have retraction of the nipple associated with the duct, and then a thick, sticky white discharge. On imaging, you may see a dilated duct, and on biopsy, inflammation. This is associated with smoking, nipple piercings. Treatment is antibiotics and observation versus excision if it's persistent and not responsive to therapy. And then Mondor's disease, this is not really an infection, but it's a thrombophlebitis of the lateral thoracic vein or branch, and that's the cord-like thing that they always describe. This is typically treated with conservative management, so warm compresses, NSAIDs, and usually resolves on its own, most commonly in the in the lower upper quadrant. What am I saying? Upper outer quadrant. Next, in benign breast diseases, so we'll talk about fibrocystic changes. This used to be known as fibrocystic disease, but they've kind of renamed it more recently. So there are a lot of different terms that can be associated with this. Fibromatosis, sclerosing adenosis, apocrine metaplasia, duct adenosis. All of these things kind of lumped together are fibrocystic breast changes. And these can be associated with breast pain, nipple discharge, which is typically in the yellow to brown color category, and lumpy breast tissue. Treatment is typically supportive again. Only need to excise this if the path shows atypical hyperplasia, because that is associated with increased risk of cancer. Benign cysts, again, usually palpable. If they're simple, you can consider aspiration. If they're persistent, but you can usually just observe them to start. And then if that FNA aspiration is bloody, or if the cyst recurs, then you can excise. If the cyst does have a solid component, it's complex, then they need a core needle biopsy to determine what it is. PASH is another kind of commonly tested term, I think. It's pseudoangiomatosis, stromal hyperplasia. These are fairly large, palpable masses, typically in young premenopausal women. They are progesterone receptor positive, so that's important to know. If they are growing or symptomatic, they can be excised. They can also respond to hormone therapy given the progesterone receptor. Fibroadenomas are kind of along that vein. So very common in young patients. 10% of patients have bilateral fibroadenomas and 15-20% have multiple. These typically change in size with menstrual cycle and with pregnancy due to the hormone fluctuations. They're well circumscribed, typically mobile, rubbery, slow growing, painless. They kind of have all the benign features that you want to see in a breast mass. In terms of diagnosis, if the patient's young, less than 35, you typically ultrasound, greater than 35, typically get a mammogram. On the mammogram, they'll describe popcorn calcifications, which I tried to show here. They look a little bit extreme in this picture, but you can kind of see these clusters of calcifications that are fairly dense. In terms of management, you can observe fibroadenomas. They typically recommend an ultrasound twice a year. And that's okay to continue observation as long as everything is concordant, meaning the exam, the imaging, all matches, and everyone agrees that this is a fibroadenoma. If there's anything that's discordant in terms of the biopsy or the imaging, or think they're not getting the right specimen from the imaging, then excisional biopsy is recommended. Also, if they're considered giant, greater than 6 centimeters, if they're growing, or if they have these complex features listed, excision is recommended. All right, Phyllodes tumor. I think I got a question on this last year, but anyway, so there's different types, benign, borderline, malignant, typically kind of classified based on different features, but one of them being the kind of mitoses per high power field. So I think less than 5 is typically benign, 5 to 10 is borderline, and then greater than 10 is typically considered malignant. About 10% of them are malignant. They're typically pretty large lesions. They do stain for vimentin and actin. On path, which is this lower picture down here, they have these leaf-like projections, and they do notably spread hematogenously. So these patients do not need a sentinel lymph node biopsy in surgery. They need a wide local excision with 1 centimeter margins. So almost treated like a sarcoma more than a typical breast cancer. And some of them may benefit from adjuvant radiation if they are malignant on their path. Nipple discharge. So malignancy does increase. Malignancy risk, it does increase with age. About 32% risk of malignancy at greater than 60 years old, and less than 40%, 4% at less than 40. So it significantly increases. It's worrisome if it's unilateral, if it's bloody, if it's serous, or if it's spontaneous. Intraductal papillomas, I think this used to always be a question. It's probably less common now because everyone knows it, but this is the most common cause of bloody nipple discharge. This is not considered pre-malignant. You can get a ductogram and then do a duct excision where you resect the subareolar tissue involved. You can localize this duct with a wire if needed. And then here's just kind of a picture with different kind of color classifications. Okay, so high-risk breast lesions. So radial scar and complex sclerosing lesion, these are kind of the same, just a kind of spectrum. So radial scars get usually less than 1 centimeter, and then a complex sclerosing lesion just has more complex features and is usually bigger. These are stellate, spiculated masses. They do radiate. You can see on the mammogram here how it kind of looks like a star burst. They have a two times increased risk of malignancy, and typically excisional biopsy is recommended. The theme of all of these high-risk lesions is excisional biopsy. So the benign things you kind of observe, and then the high-risk lesions, typically excisional biopsy to make sure there's nothing else there. So going on with more high-risk breast lesions, so atypical ductal hyperplasia is pre-malignant. They have 4 to 5 times increased risk of malignancy. You can see many are upgraded to DCIS and some even to invasive ductal carcinoma. They get an excisional biopsy. Lobular hyperplasia is not considered pre-malignant, but it does significantly increase their risk of malignancy elsewhere. So they have an 8 to 12 times increased risk. They still recommend excisional biopsy for these, just to make sure there's nothing else going there, given the high rate of sampling error. They are potentially considered for chemo prevention, hormone therapy, given their increased cancer risk. LCIS similarly is not pre-malignant. They do have a 20 to 40% risk of cancer development in either breast. They're mostly hormone positive. You don't see calcifications typically, and again, excisional biopsy. There are some worse variants, pleomorphic LCIS in particular, that is treated like DCIS, so treated more similar to cancer. Okay, so moving on to DCIS. So these are malignant cells, so cancer cells, but they have not invaded the basement membrane. So you can see in this picture up here, they're kind of staying within that duct and not escaping it. 50% risk of invasive cancer if you have DCIS in that breast, and then 5% in the contralateral. This is considered pre-malignant, so it's expected to progress to cancer with time. You will see calcifications typically on mammogram with this, kind of in clusters as shown down here. There is again, a more high-risk pathology, the comedo pattern that may be tested, and these patients are recommended for mastectomy. If they don't have that, the typical treatment recommendation is either a lumpectomy with adjuvant radiation versus a mastectomy with sentinel lymph node biopsy. For DCIS, they do recommend 2 mm margins still because of the risk of having kind of these skip lesions where you have another area that's a little bit away from the primary because they're not a focal mass. They also are usually hormone positive, and so should be treated with endocrine therapy adjuvantly, either tamoxifen or anastrozole, depending on menopause status. Okay, so talking about cancer now. So breast cancer is unfortunately very common. About 1 in 8 women are expected to develop it in their lifetime. So we recommend screening with the mammogram starting at age 40. There's variations in screening guidelines. There are many different societies. I think the safest answer is just to say annually at age 40 for ABSITE, though I don't think they can ask you the variation. So there is a pretty high risk of false positive, about 50% over 10 years. So many women end up getting called back for additional imaging or biopsies. One of the critiques of mammogram. There are people obviously who are higher risk, have genetic mutations. BRCA is most common, Lee-Fermani, Cowden, NF1, Peutz-Jeghers, CDH1, CHEK2, PLB2. All of these patients would be recommended to go to have more frequent screening with mammogram plus or minus MRI. For BRCA, they recommend MRI and mammogram. So every 6 months, you'd get imaging starting at 25. Risk prediction models. So these are used to kind of assess women's risks. Typically 20% is used as high risk, and those patients would be the ones that are recommended to maybe get additional MRIs or get more frequent mammograms. And then on the right, I have the BI-RADS classification. So this is when we look at mammograms, how we classify lesions. The thing that I'd like to remember for this is if it's, a BI-RADS 3 is the one that they need repeat imaging, because 1 and 2, you just routine follow-up. 4, 5, you need biopsy. So 3 is really what you need to remember as in terms of the kind of one that they'll test on. Okay, staging. So TNM staging is kind of the old school staging, and then now they're adding in these genetic and biomarker testing to kind of help guide treatment in addition. So you can look at this. I don't think I need to read it right now. But I think in terms of talking about the genetic and biomarker testing, so receptor testing is essential in breast cancer. You get estrogen receptor, progesterone receptor, and HER2 testing, and then genomic assays. So now we use things like an oncotype or mammoprint, which are brand names of these tests, to look at gene panels of this specific tumor, and these help predict the recurrence of that specific patient's cancer and then guide the chemotherapy recommendation. So it's no longer, well, if you have nodes, you need chemotherapy. It's, what does your actual cancer look like, and what is your risk of having a recurrence, and, do you need chemotherapy? And then obviously genetic testing to try to evaluate risk from that is important. Okay, so we kind of talked about already, but there's invasive ductal and invasive lobular. Ductal is much more common. 85% of breast cancers comes from the ducts. It does have some subtypes. Usually see a mass or asymmetry in terms of imaging. Margins for the excision of these cancers is just no ink on tumor. So you do not need the 2 millimeters that you need with DCIS. Treatment is typically mastectomy with a sentinel node or breast conserving therapy, which is the lumpectomy with radiation plus a sentinel node. And then same with lobular cancer, the treatment is the same. We used to say that lobular had an increased risk of contralateral cancer, but now they don't really say that so much. So I doubt that's going to come up anymore. Same margins. So I think you can manage these largely the same. Inflammatory breast cancer is kind of an important subset that's often tested. So these are the rapid onset, it's skin involvement. The kind of pathognomonic term is that you'll see dermal lymphatic invasion on a punch biopsy of the skin. The breast will be warm. They say, I spelled it wrong, potent orange. Anyway, treatment for these, they need neoadjuvant chemotherapy and then they need a modified radical mastectomy or MRM. So this means you're going to take the entire breast and then do an axillary dissection. They'll also need adjuvant chemo and radiation afterwards. So this is kind of, they're going to get all of the treatment that we have to offer. Paget's disease of the nipple is also commonly tested. These are, you'll see kind of like a plaque on the nipple. They need a mammogram and an ultrasound to rule out underlying cancer, but most of the time they have a DCIS or an IDC in 90% of the cases. You'll do a biopsy and see these cells with clear cytoplasm and large nucleoli. Treatment for this is mastectomy with resection of the nipple areolar complex and a sentinel lymph node. Male breast cancer, I'll just mention quickly. It's not very common, but it is associated with specific genetics, like especially BRCA2. The textbook says these patients should get a modified radical mastectomy, though in clinical practice, I don't think this is always done. But I think that's the safest answer on the ABSITE. And then in pregnancy, there's a few, they love to ask questions about breast cancer and pregnancy because there are a few things that you can and can't do. So they can never get hormonal therapy, so no endocrine therapy. They cannot get radiation anytime during pregnancy. They cannot get methylene blue or any kind of blue dye to use as a radio tracer. They can get breast conserving therapy if they're late in pregnancy because they could have a lumpectomy and then have their radiation after they deliver. And then chemotherapy can be done during pregnancy. I think it's often thought it can't, but after the first trimester, many of the chemotherapy agents are safe. So that could be an option. And then talking about different surgery for breast cancer. So breast cancer surgery. So partial mastectomy with a sentinel lymph node and adjuvant radiation is considered breast conserving therapy. That is considered equivalent in terms of cancer outcomes, life expectancy, long-term survival to the simple mastectomy with sentinel lymph node biopsy. So mastectomy equals lumpectomy with radiation. The mastectomy would obviously be removing the entire breast, and there are variations where you can spare the skin or even spare the nipple. And then the modified radical mastectomy would be the removal of the breast, so combining a mastectomy with the axillary dissection. Sentinel lymph node biopsy is, like we talked about, using a radio tracer and or a blue dye to localize sentinel nodes, typically 1 to 3 nodes. There is some risk of anaphylaxis or skin necrosis with blue dye use, and it's contraindicated in pregnancy. And then here I've listed some of the contraindications to breast conserving therapy, which you can read. Let's see. Okay, so talking about axillary dissection. So here they recommend removing levels 1 and 2, as we mentioned in the anatomy. It is indicated for patients who have clinically positive nodes, so there's ongoing trials that are evaluating this, patients who have inflammatory breast cancer, and if per Z11, patients have 3 or more positive lymph nodes in their sentinel node biopsy. So the Z11 trial is very important. It's very often tested. This trial determined that it was okay to omit the axillary dissection in patients who met a certain criteria. So those are that they had a T1 or T2 cancer, so it's 5 centimeters or less in size, and they were undergoing breast conserving therapy and whole breast radiation. So these patients were not getting mastectomies. They were clinically node negative, so they didn't have any palpable nodes, and they had 1 or 2 positive nodes on their sentinel lymph node biopsy. And so they found in these patients there was no difference in local recurrence, overall survival, cancer outcomes if they got an axillary dissection or sentinel node. So that's very important. Axillary dissections are very morbid, associated with lots of complications, lymphedema, infection, and so if we can avoid them, that's great. Okay, and then last, I'm going to talk about radiation chemotherapy really quick. So, radiation is administered after lumpectomy. It's whole breast radiation, and that's part of the breast conserving therapy package. You may need adjuvant radiation after a mastectomy in specific cases. So, these are typically larger cancers that are involving the chest wall or the skin. If the patient has very advanced nodal status, more than 4 nodes, internal mammary node involvement that they can't operatively remove, positive margins, or the tumors, like I said, large, T3 or T4. So radiation always with breast conserving, and then sometimes after a mastectomy in kind of more aggressive cancers. Then chemotherapy and hormone therapy. So the typical regimens to know is ACT for, this would be for triple negative cancer, for some of the hormone positive cancers, depending on those oncotype and mammoprint scores that would say whether a patient's hormone positive cancer, would be more aggressive and potentially need chemotherapy. So it's important to know they like to test on these kind of toxicities of chemotherapy agents. So neuropathy with the taxanes, cardiomyopathy with the adriamycin, and then cyclophosphamide, the hemorrhagic cystitis. And then TCHP is the regimen for HER2 positive cancers. So they get the taxane and carboplatin, but then they also get Herceptin and Perjeta, which are targeted to the HER2. And then, like I said, these are kind of considered based on stage, nodal status, and these genomic assays that predict the risk of recurrence. And then hormone positive cancers will also always get hormone therapy. They may also get chemotherapy depending on their tumor biology. So typically in premenopausal women, you're going to do a SERM, like tamoxifen for 5 years. Postmenopausal, they're going to get an aromatase inhibitor like an anastrozole for 5 years. And then HER2 positive, they'll get Herceptin for 1 year. And I think that is all.
Wow, Mackenzie, that was amazing. I wish I would have seen this before I took ABSITE, at least like one time in residency. That was a really good high yield. I would say like pregnant patients with breast cancer is like everybody loves to ask questions about that. But that was awesome. If you have any questions, feel free to send them in the Q&A and we'll address them at the end. But we're going to move on next to colorectal with Hillary Johnson from University of Wisconsin.
Perfect. It's happening slowly, but my computer's trying to cooperate. Okay. All right. Everything look good on your end, Connie? Okay, perfect. Like Connie said, my name is Hillary. I'm a chief resident at the University of Wisconsin, heading to U Chicago next year for colorectal fellowship. When I took the ABSITE, I always felt like the colorectal pieces that were challenging for me were the surveillance and then treatment of colorectal cancers. And so I focused the talk tonight kind of more on that since it's a shorter amount of time with which to work. So I'm just going to start with a case study to kind of get you guys thinking. We have a 38-year-old who shows up to her PCP's office to discuss cancer screening. She denies any GI complaints. She's never had a colonoscopy before, and she doesn't recall any family history of IBD or colon cancers. So at what age should we begin colorectal cancer screening for this patient, and what sort of screening tests are available, and what would you recommend? If her father had a diagnosis of colon cancer at 52, how would that change what you recommend? If she herself was diagnosed with Crohn's disease at 22 years of age, would that change what you recommend? And then if she had family history of a genetic condition such as HNPCC, would that change what you would recommend in terms of her screening and surveillance? So just as a reminder, the U.S. Preventative Task Force recommends screening for all adults with colorectal cancer starting at age 45 and then extending into at least 75 years of age. Colon and colorectal cancer is got an increased incidence in young people from 2000 to 2014, almost a 15% increase, and it is the second most common cause of cancer deaths in the United States currently. There is some discussion about continuing colon cancer screening past 75 years of age. In the 76 to 85-year-old population, it's sort of a shared decision making given kind of their other comorbidities and life expectancy. And then the options available for colon cancer screening include stool-based tests every 3 years. So that would be an FOBT, which is just detecting blood itself, or a FIT test, where it's detecting blood antibodies, versus the stool DNA test, something like a Cologuard, which detects DNA biomarkers for cancer. And I've seen this specifically on the ABSITE, like what's the difference between a FIT test and a Cologuard test. So it's something to keep in mind. And then more direct visualization tests, such as CT colonography, which is X-ray CT based every 5 years. This isn't something that I personally have seen, but I Googled it, and here are some examples on the right here of kind of what that looks like, versus the traditional colonoscopy every 10 years. There are some exceptions to colon cancer screening guidelines. In patients who have a family history, first-degree relatives with colon cancer, we recommend starting screening at age 40 or 10 years before the diagnosis of that first-degree relative. So for our patient whose father was diagnosed at 52, she would begin screening at 40. And then for patients with inflammatory bowel disease, in Crohn's disease patients, they recommend colonoscopy beginning 8 years after diagnosis, or when a patient is diagnosed with PSC. And then similarly for ulcerative colitis, colonoscopy 8 years after start of symptoms. Here are some other genetic disorders and kind of the recommended screening protocol for them. As a reminder, FAP is an autosomal dominant mutation in the APC gene. It's recommended colonoscopy begin at age 12 or puberty, whichever is first, and it's done every 1 to 2 years for these patients. And then they are also recommended to undergo prophylactic colectomy in early adulthood after they complete puberty. I didn't include it in this slide, but other screening things for FAP include EGD beginning at 25 to 30 years of age, and repeating that kind of depends on the degree of polyposis in the upper GI tract. And then considering, in addition to that, based on kind of family history, annual thyroid ultrasounds on a case-by-case basis, as well as liver ultrasounds in FAP families who also have a history of hepatoblastoma. So they would get liver ultrasounds and AFP levels as children until the age of 7. Next is hereditary non-polyposis colorectal cancer, or formerly Lynch syndrome, also an autosomal dominant condition, which is a mutation in MMR genes. They recommend beginning colonoscopy at age 20 to 25 and repeating every 1 to 2 years. Additionally, for women, they recommend annual bimanual exams with endometrial sampling and transvaginal ultrasounds to screen for endometrial cancer starting at age 30 to 35, as well as considering prophylactic hysterectomy and bilateral salpingo-oophorectomy. These patients also should get a baseline EGD at age 30 to 35, and then consider EGD every 2 to 3 years for upper GI cancer screening. Next is Peutz-Jeghers syndrome. You may recall this is the condition that is associated with mucocutaneous pigmentation at the lips. They are at increased risk for GI and other extraintestinal cancers. It's an autosomal dominant process, and the mutation is in the STK11 gene. It's recommended for these patients that they begin colonoscopy early at age 8 and then have it every 3 years. And then it's also recommended that they undergo upper GI screening. It seems more leaning towards a small bowel, like capsule endoscopy or CT enterography for these patients. And then finally, MUTYH-associated polyposis, or MAP, which is an autosomal recessive disorder. I hadn't heard as much about this one, but they recommend colonoscopy beginning at age 20 to 25 and every 1 to 2 years for these patients as well as periodic EGD, but they didn't have kind of a hard, fast number of years recommended for these conditions. So we'll continue with our case study. So our 38-year-old female returns at 45 years of age, which is when it's recommended for her to undergo her screening colonoscopy. The colonoscopy is performed, and it's notable for a single tubular adenoma in the cecum, 11 millimeters in size, that's able to be completely resected via snare. So consider when you would repeat colonoscopy for this patient, and then if the patient didn't have any lesions or pathology on colonoscopy, when would you recommend repeat? Or if it demonstrated kind of a large burden of adenomas, would that change what you recommend? So here's a big table with a lot of words that kind of goes over all the different colonoscopy surveillance intervals, and I feel like this comes up a lot on the ABSITE. And I try to think of it as 10 years versus 3 years in my mind when I'm doing test taking strategies. So for a normal colonoscopy without any findings, you would do a repeat colonoscopy in 10 years. If you had 1 to 2 small adenomas, you could do 7 to 10 years. So I just tell myself 10 years for that. And then if you have 3 to 4 tubular adenomas that are small, 3 to 5 years, and then 5 to 10 that are less than a centimeter, then again, 3 years. So I just group all that together as 3 years. Same with tubular adenomas greater than 10 millimeters, as well as any or higher risk features such as tubovilus or villus histology, and high-grade dysplasia in your adenoma or cess-ulcerated polyps. And then things get a little more complicated when you're talking about additional, like a large amount of adenomas. So if you have greater than 10 adenomas on a single exam, then it's recommended that you repeat a colonoscopy in 1 year and consider genetic testing for these patients. And then if it's removed piecemeal, you would repeat a colonoscopy at 6 months. And then the cess-ulcerated polyps kind of follow a similar timeline to the adenomas, as well as larger hyperplastic polyps. All right. So this patient, because of her single large tubular adenoma, it's recommended that she return for her colonoscopy at 3 years. Repeat colonoscopy at that time demonstrated a cecal mass, and pathology returned as a cecal adenocarcinoma. So I'll give you guys a second to think of what other workup would you recommend for this patient, and how would you stage this colon adenocarcinoma? What would you do kind of for your staging workup? So if you said that for staging workup, you would get a CT chest, abdomen, pelvis, you would be right, but it's also important to get a CEA, a CBC, and a CMP if the colonoscopy wasn't completed at the initial identification of this mass, and you would do a complete colonoscopy. Given this patient's age, you could also consider a genetics referral, and then you would want to further stage the lesion. So I included this table here, another table with lots of words, but I think this does come up a decent amount on the ABSITE when you're talking about staging, and for colon cancer specifically. We'll get into rectal cancer later, kind of like what the surgical recommendations are based off of staging. And so just a kind of general reminder that for colon cancers, we recommend surgical resection with 5 centimeter margins, if you can anticipate an R0 resection. And then you want 12 lymph nodes as part of that resection. So here's kind of going through the TNM staging. You can see that for stage 1 disease, you would do resection. And then for stage 2, B is a little bit more nuanced because it's T4, meaning it could be invading into other structures. So if it's invading into other structures, then you would consider neoadjuvant therapy. Otherwise, stage 2 diseases also, and stage 3 diseases upfront resection. Stage 4 disease is more distant metastatic disease, so you would do systemic therapy for these patients. All right, so your patient comes back with their new diagnosis of cecal adenocarcinoma. They undergo their staging workup, which demonstrates on CT a cecal mass without any evidence of regional invasion or metastatic disease. And so she's recommended to undergo minimally invasive right hemicolectomy. She goes through the procedure, and final pathology demonstrates a stage 2 T3 and 0 M0 lesion with 0 positive lymph nodes, and 15 were obtained out of the 12 needed. So she is referred to medical oncology for discussion of adjuvant therapy, and then we want to talk with her about surveillance. So I'm just going to quickly go back to this slide. You want to consider adjuvant therapy for any stage 2 or greater disease, and T3 is invading through the muscularis, but is not invading into any other organs or structures. So she's asked you what you want to do for surveillance in terms of her cancer. And here's kind of the general workup and surveillance for colonoscopy intervals and et cetera after treatment of colon cancer. So for stage 1 disease, you just repeat a colonoscopy at 1 year. And then if there's no advanced disease found on that colonoscopy, then you go out to every 3 years. For stage 2 and 3 disease, like this patient, you will do H&Ps and CEAs every 3 to 6 months for the first 2 years, and then every 6 months for a total of 5 years following that, as well as CTs of the chest, abdomen, pelvis every 6 to 12 months for the initial 5 years. So to simplify that in my brain, I just say that, you know, for the first 5 years, you're being seen basically every 6 months. And then colonoscopy at 1 year after your cancer resection, unless there was an obstructing lesion and the colon wasn't able to be completely cleared, then you would wait for the colon to heal. And then at 3 to 6 months, you would repeat your colonoscopy. And then for stage 4 disease, you would do H&P and CEA every 3 to 6 months for 2 years, similar to stage 2 and 3. And then CTs every 3 to 6 months, which is more frequently than stage 2 and 3. And then you would also consider PET CTs for these patients. And again, colonoscopy at 1 year, unless there's obstructing lesions, and then go out to every 3 years from there. All right. So next we're going to talk a little bit about rectal cancer. So just as a reminder, the rectum is in about 12 to 15 centimeters in length. This is the most distal part of the colon. The upper third of the rectum is typically managed like colon cancer, so as we just discussed, and then the lower 2/3 of the rectum is managed a little bit differently. The staging workup is similar. You complete a colonoscopy if a completion hadn't been performed. In addition to that, you would do a digital rectal exam, a flex sig, or rigid proctoscopy to evaluate where in the rectum this lesion is more clearly. You would do CBC, CMP, and CEA, CT chest, abdomen, pelvis, and then you would also add on endoscopic ultrasound or pelvic MRI to better characterize the depth of invasion in the local regional lymph node staging for these rectal cancers. And here, similar to the colon cancer, is the rectal cancer staging. It is almost identical in terms of, well, it is identical in terms of T&M staging. The treatment is a little bit different. And so for stage 2 and 3 rectal cancer, neoadjuvant chemoradiation is recommended before resection, whereas in colon cancer, you often do upfront resection. So you can see the differences there. Stage 2A through stage 3C are all getting neoadjuvant chemorads prior to resection, and then also considering adjuvant chemotherapy after resection. And then stage 4 disease, again, is treated with systemic therapy. And just as a reminder, total neoadjuvant therapy for rectal cancer is often systemic FOLFOX plus chemoradiation in the neoadjuvant setting for the stage 2 and 3 disease. This has been shown to reduce local recurrence, improve disease-free survival. It has led to a higher sphincter preservation rate, so people can then undergo LAR rather than APR. Lower anastomotic stenosis rates and longer long-term survival. And again, similar to colon cancer, you do a resection, but the nuance there for rectal cancer is the decision-making between a low anterior resection and an abdominal perineal resection. So LARs are for the more proximal rectal cancers without sphincter involvement. You can restore GI continuity for these patients. Sometimes you will give them a diverting ileostomy. And then APR is removing the entire rectum and anus with a permanent ostomy. This is for rectal cancers within 5 centimeters of the anal verge, sphincter, pelvic floor involvement, or with poor baseline continence and function. And for these patients, a 1 to 2 centimeter distal margin is acceptable based off the more current literature, as opposed to colon cancer, where we usually tried for 5 centimeter margins. And then we also recommend total mesorectal excision as well as the 12 lymph nodes, which is just the same as colon cancer. For rectal cancer, similarly, you do long-term follow-up every 3 months with a CEA. You also do a digital rectal exam every 3 months, and then annual CTs for 3 years, as well as colonoscopy at 1 year, and then going to every 3, depending on the findings of that first year. Some special considerations for colorectal cancer. I feel like this question about MMR deficient and microsatellite unstable colon and rectal cancers comes up a lot. These microsatellite instability high tumors and the MMR deficient tumors actually have better outcomes due to being susceptible to the immune checkpoint inhibitor medications. And so that's something to consider. In the converse of that, the P53 and the KRAS mutations in rectal cancer seem to be more poor responders to neoadjuvant chemotherapy. And then the other consideration for rectal cancer, which I don't know if will show up on the ABSITE, is watch and wait. And so this is for those often patients who would require APR due to the location of their cancer and have low-risk tumor features, which include extent of disease, low CEA, they are MMR deficient or microsatellite unstable, and have a complete clinical response to neoadjuvant chemoradiation. Rather than proceeding with surgery, they can go into a surveillance protocol with regular DRE, MRI, and endoscopy, and I believe that is, every 3 to 6 months for an extended period of time. And then, if they were to develop disease, then they would undergo excision at that point. Some other special considerations. I feel like there are some questions that come up on the ABSITE too about when you have synchronous colon cancer with hepatic metastasis. And so it's always been hard for me to kind of figure out what is the best strategy for that. But those strategies include doing upfront resection of the primary and the metastasis at the same time, or staged operation where you do either just removing the cancer or the metastatic disease, or adding systemic neoadjuvant chemotherapy versus adjuvant. And both ASCRS and the NCCN don't recommend one strategy over the other. It's sort of their consensus statements say it should be determined by a multidisciplinary tumor board, and that any surgery should be delayed at least 4 weeks after their last chemotherapy if they're getting neoadjuvant chemotherapy. For larger hepatectomies or more high-risk anastomoses, like a low rectal anastomoses, that may benefit from a staged operation rather than doing those two in the same operation. And then I don't know how we're doing on time, but I'm going to just cover quickly a couple other colorectal cancers that may come up. Appendiceal cancers are rare cancers. They often present as appendicitis. Appendiceal adenocarcinoma is either treated by appendectomy versus right hemicolectomy. Appendectomy is appropriate for well-differentiated T1 tumors so that they're not extending beyond the submucosa, and then not extending into the cecum. And then right hemicolectomy is recommended for any more advanced disease. Similarly, neuroendocrine tumors, which are the third most common, neuroendocrine tumors of the appendix are the third most common site for neuroendocrine tumors, generally are treated based off of size and extension. So anything less than 2 centimeters can be treated with an appendectomy, or greater than 2 centimeters, you would do a right hemicolectomy. And then the Lamans and the Hammonds can do appendectomy if limited to the appendix and can obtain negative margins. Otherwise, right hemicolectomy and considerations of HIPEC. And then I think this is my last slide, just to quickly refresh everyone that anal rectal melanoma is also a consideration. They're pretty rare and they're often amelanotic, so hard to visualize on exam. But the recommendation now is wide local excision if you can obtain appropriate margins. If not, you would have to do APR. There is data to support that they have similar survival. And then also adjuvant therapies for melanoma. And then squamous cell carcinoma of the anus is HPV associated. It has high risk HPV strain 16 and 18. I feel like I've seen that question a bunch. Risk factors include immunocompromise, tobacco use, HIV status. For cancers in the anal canal, the recommendation is chemoradiation with the NIGRA protocol. I put what it goes into the NIGRA protocol here. And then if it's not responsive to the NIGRA protocol or recurrent after that, you would do APR for salvage. And then for anal cancer at the anal margin, which is within 5 centimeters of the anus, kind of circumferentially wide local excision with 1 centimeter margins. And here's some references. Thank you guys for your time. Happy to take any questions at the end.
Awesome. Thank you, Hillary.
No problem.
That's great. Condensing all of colorectal in 20 minutes. Just my entire year of fellowship. 20 minutes. No, that's awesome. And everybody that's listening in, we're about halfway done. Next up, we have foregut and thoracic with Mitchell Wan from Loma Linda. He will give us a 20-minute talk on the foregut and thoracic topics.
Let's see if this is sharing. Is this? I am screen sharing. Okay, are you guys able to see the presentation?
Yeah, we can see it.
Okay, so this is going to be the review of foregut and thoracic. There's kind of 3 systems we're reviewing, so definitely more of a greatest hits review than comprehensive. First of all, we have the esophagus. It's split up into 4 parts. You have the cervical, upper thoracic, lower thoracic, and abdominal sections. The cervical esophagus is supplied by the inferior thyroid artery. Upper thoracic gets branches from the bronchial artery. Lower thoracic gets blood supply directly from the aorta. And the abdominal esophagus gets blood supply from the left gastric and phrenic arteries. At the top, you have the cricopharyngeus as your first narrowing, most common site for foreign bodies to get stuck. The upper thoracic, the esophagus gets pressed on by the aortic arch in the left bronchus, and then you have the diaphragmatic pinch leading to the stomach. Accessing the esophagus is generally through the left side, either through the left neck, or the left chest. If you're on the upper thoracic section, you want to dodge the aorta and access to the right chest. Abdominal esophagus you can get through a laparotomy incision. The wall has 4 layers: mucosa, submucosa, muscularis propria, and adventitia. There's no serosa, so that's why cancer tends to invade faster than other places of the alimentary tract. You have the Auerbach plexus in between that inner circular muscle and outer longitudinal muscle in the muscular layer that helps perpetuate your migratory motor complexes. Innervation is LARP, live action role play, left anterior, right posterior. The left vagus goes to the liver and biliary tree. The right vagus becomes a celiac plexus. The upper esophageal sphincter is innervated by the recurrent laryngeal nerve, which is why if you get a brainstem stroke, you're at high risk for aspiration because that muscle can no longer relax. The upper 1/3 of the esophagus is striated muscle, and the lower 2/3 is smooth. The upper esophageal sphincter is again the cricopharyngeus, and the lower esophageal sphincter is contracted at rest. In terms of motility, I think it's easiest to think of this about what's a normal esophagus before thinking about what they're trying to tell you with your studies. So you should be having less than 10% contractions, amplitude of less than 100 millimeters of mercury, and a DCI distal contractile interval of less than 5,000. The lower esophageal sphincter is a low pressure system, should be under 30 millimeters of mercury and go to 0 as you're swallowing. And relaxation pressure should be under 15. For achalasia, you'll notice on the esophagus, you have distal aperistalsis. It's the only pathology where the lower esophageal sphincter has high relaxation pressure because it can't relax. On biopsy, you'll see there's a loss of the Auerbach plexus. This is associated with Chagas disease or infection with Trypanosoma cruzi. And you'll see that classic bird's beak on your upper GI. Treatment, you do conservative measures first with endoscopic therapy, Botox or balloon dilation. If that fails, you need to go to surgery. You can do a lower myotomy and incorporate a toupee fundoplication to hold open your myotomy, or a door fundoplication if you exposed any mucosa. There's a couple types of achalasia. The important type to keep in mind is type 3, which is premature contractions with distal latency. I got a question on SCORE that was telling me that POEM or per oral endoscopic myotomy is the best treatment for that. So it may be popping up on ABSITE. Distal esophageal spasm has a lot of simultaneous contractions. Your peristalsis doesn't work correctly. On upper GI, you'll see a corkscrew esophagus, usually comorbid with site conditions or anxiety, so you can treat those. Medical treatment is nitrates, calcium channel blockers, or Viagra to relax your muscles. And if that fails, you go to a long segment myotomy of the upper and lower muscles. Nutcracker esophagus has a high amplitude over 180, a DCI of over 8,000. Normal LES, upper GI can be normal or show corkscrew. Treatment is, again, medical things to relax the muscles, nitrates, calcium channel blockers, or Viagra, and a long segment myotomy if that fails. You may get tests on ineffective esophageal motility. That's when your esophagus has low amplitude contractions and a high number of non-transmitted contractions. Lower sphincter is, again, normal. Treatment, there's no surgery for this. It's just treat the symptoms of reflux if they're having them. Scleroderma can cause total aperistalsis of your esophagus as it turns into rock. Treatment of this is PPI and promotility agents to stop your stomach from being full. And if severe, they may need a esophagectomy. Diverticula is Senker diverticulum associated with elderly males. Location in the posterior cervical triangle due to your cricopharyngeus being too tight. Treatment is to divide the cricopharyngeus with or without a diverticulectomy. If your Zenker diverticulum is under 2 centimeters, you can get away with only a myotomy. Traction diverticula happen at the lateral thoracic esophagus associated with friction or inflammation, aortitis, tuberculosis, or tumors. Treatment for these are remove it if it's symptomatic, with or without radiation if it's due to cancer. You can get epiphrenic or pulsion diverticulums, usually distal on the right side of the esophagus. From motility disorders, you can take out the diverticula and add in a Heller myotomy if it's due to achalasia. For Barrett's esophagus, that's squamocolumnar metaplasia, secondary to long-term untreated GERD. You'll see goblet cells on biopsy, very high risk of cancer. These patients should get 4-quadrant biopsies every 1 centimeter along the area of dysplasia and any other abnormal areas. There's the 3-6-3 rule, where if you have Barrett's and no dysplasia, you get an EGD every 3 years. If you have low-grade dysplasia, you get an EGD every 6 months. And if you have high-grade dysplasia, you need to treat that endoscopically and EGD them every 3 months for high-risk surveillance, or you can proceed to esophagectomy at that point. Important to note that even if you treat them with PPI and fundoplication, their cancer risk does not go down and you need to continue screening. For hiatal hernias, type 1 is sliding when your gastroesophageal junction moves up and down, associated with Scotty rings. You shouldn't resect these, you should just dilate and give them a PPI. Type 2 is perisophageal when their stomach herniates into their chest, usually the fundus. These are at the highest risk for ischemia, associated with developing Cameron ulcers in the stomach. Also can have torsion or gastric volvulus with these. Important to note the Borchardt triad, which is a classic sign of gastric volvulus when you have epigastric pain, retching, and the inability to pass the NG tube. Type 3 is type 1 plus type 2, and type 4 is the stomach and another organ in the chest. You should fix any of these if they're symptomatic, but important to note that patients, when they present with this, are often pretty old and are poor surgical candidates at that point. The general concept of fundoplication, you cut the short gastric arteries, you retract the esophagus into the abdomen, you do a cruroplasty to tighten up the diaphragm, throw a bougie into the esophagus to avoid over-tightening, and then choose what kind of wrap you're going to do. 360 posterior is your Nissen, 270 degrees posterior is your toupee, 180 anterior is a door, and if you go through the chest, that's called a Belsey. If you don't have enough esophagus to pull down, you can take a wedge resection of the stomach to lengthen the esophagus, which is called a colus gastroplasty. You need at least 3 centimeters of esophagus to perform your wrap. If you're having dysphagia after a Nissen fundoplication, your wrap is too tight, you can usually avoid surgery, give them clears for the first week, and then dilate them afterwards. For caustic ingestion, bleach is worse than acid. Bleach gives you a liquefactive necrosis, very scary. Your initial management should be a chest x-ray, an exam, and don't put an NG tube in there. You'll get a CT chest and abdomen with a little bit of oral contrast to see if they're perforated. You should scope them within 1 to 2 days if they're stable and there's nothing obvious on the CT scan. You should not traverse a severe injury. You should stop right when you see it. And if they're not perforated and stable, you admit to the ICU for IV antibiotics and NPO and monitoring. On the right is the Zarger classification for esophageal damage after caustic ingestion. Primary burns will show hyperemia. You can treat that with observation, fluid, spitting, antibiotics, and trial them with PO after 3 to 4 days. They may develop strictures, which will need to be dilated. Secondary burns, you'll see ulceration, sloughing, and exudate. You do the above and add on TPN because you're predicting a prolonged NPO. If they perforate, they need an esophagectomy. Tertiary, that's E and F in the pictures. Very likely to perforate. If they do perforate, you go to surgery. You need to give them a spit fistula, divert their esophagus. You need to give them some sort of enteric access. Usually, in the case of caustic ingestion, that's a J tube because their stomach is also damaged and considered colonic interposition for later reconstruction. Esophageal perforation most commonly happens iatrogenically after getting scoped, but can also happen with Boerhaave syndrome with forceful retching or vomiting. That usually perforates the lateral wall 3 to 5 centimeters above the GE junction. Physical exam finds Hammond's crunch, which is crunching in the mediastinum with each heartbeat. You should get a gastrograph and esophagram for these patients. If it's a late perforation over 2 days, they'll need an esophagectomy or resection versus draining widely and diverting their esophagus and getting them some feeding access. If it's within 2 days of the perforation and it's minimally contaminated, you can try to repair it. You should extend your myotomy proximal and distal to see how much of the mucosa is injured. Then you close the mucosa, close the muscle, cover your repair with a flap of something, usually muscle. If the lower esophageal sphincter is perforated, like they were getting a dilation for achalasia, perform myotomy on the opposite side of the perforation and do a door fundoplication to cover it. After this, you should place an NG tube and a chest tube. Just an interesting picture I found. If they do have a G tube and an esophagostomy, you can just connect them so they can drink. Benign esophageal disease, the ABSITE likes to test on. Leiomyoma is the number one. You'll see a smooth round lesion arising from the fourth layer on EUS. You shouldn't biopsies. There's a risk of scarring and perforation. If it's under 5 centimeters, you can resect endoscopically. If it's over 5 centimeters, you should go from the outside and enucleate the lesion. If it turns out to be leiomyosarcoma, they need an esophagectomy. Plummer-Vinson syndrome, that's the iron deficiency. Syndrome where you get the spoon nails and the esophageal webs. You can just dilate those. For esophageal cancer, the upper esophagus gets squamous cell carcinoma more often, associated with friction or irritation like smoking and alcohol. Also scleroderma. Adenocarcinoma is caused by increased acid exposure like GERD, obesity, Barrett's esophagus. Achalasia, interestingly enough, increases your risk for both. For staging, the important one to know is once it's T2 or over, you can't go straight to surgery. They need some neoadjuvant therapy, also if their nodes are positive. You can endoscopically resect low-risk T1A lesions or non-surgical candidates, and you should get 15 nodes during surgery. For the CWART classification, based on the tumor's relation to the GEJ, basically you treat at the GEJ or above the GEJ as esophageal cancer and they get an esophagectomy. And then if it's below the GEJ, you treat it like gastric cancer and they get a gastrectomy. You're probably not going to be tested on the details of Ivor-Lewis esophagectomy, but important thing to note is if they did have this and your gastric conduit does not do well, if it dies or leaks, you should treat it like damage control surgery, divert their esophagus, get them feeding access, and then consider some kind of colonic interposition later on. Okay, for stomach, there's 5 blood supplies to the stomach: right gastric from the proper hepatic artery after the GDA, left gastric from the celiac trunk, right gastroepiploic from the GDA, left gastroepiploic from the splenic, and short gastric arteries from the splenic. This is why you have a small risk of gastric perforation after a splenectomy, especially in your trauma patients who are very unstable. Innervation, same as the esophagus, LARP, left anterior, right posterior. You have the criminal nerve of Grassi from the right vagus, which you need to remember if you're doing a highly selective vagotomy, if you want to have a good results in your surgery. Truncal vagotomy is cutting the vagus right at the trunk, and then highly selective allows you to preserve the crow's feet that innervate the pylorus and not have to give them a pyloroplasty at the same surgery. Bezoars, phytobezoars are made out of food associated with gastric motility issues like gastroparesis or prior gastric surgery. You can give them full sugar Coca-Cola. The diet is not acidic enough to work. They can eat some meat tenderizer. You can ingest cellulase, or you can try to break it up with the EGD. If none of those work, then you do surgery and take them out. Trichobezoars are hairballs associated with sight conditions and kids because they like to eat hair. These are hard to dissolve or treat endoscopically. They usually need a gastrotomy and removal. Gastroparesis associated with both of these, diagnosed with the gastric emptying study. Treatment for these is first-line medical, Reglan or erythromycin are your motility agents to increase gastric emptying. But if it's refractory to medical treatment, you do remove the stomach and give them a Roux-en-Y. For ulcers, H. pylori testing, the biopsy is a gold standard. There's a stool antigen test and a serum IgG. The IgG cannot distinguish between past and present infection. And they'll put the urea breath test on there, which you need to know is the best test for eradication, but not good for testing, not used for screening. For peptic ulcer disease, the important ones to know are the type 2 and type 3, which are associated with high acid production. These can be treated with a vagotomy. Treatment for peptic ulcer disease is triple therapy, but if you have resistant H. pylori to clarithromycin, then you recommend quadruple therapy, which is the PPI, flagyl, tetracycline, and bismuth. You always tell these people to stop smoking, stop their NSAIDs, and usually to stop alcohol. Cushing ulcers are associated with head trauma and are located in the stomach. Curling ulcers are associated with burns and are in the duodenum usually, and the Cameron ulcers, again, are associated with hiatal hernias and are at the neck of the hernia. For GI bleeding, if someone's bleeding from their stomach, you do an EGD, they can clip, you can inject in 4 quadrants with epinephrine, you can cauterize. If they have variceal bleeding, you can do bands or sclerotherapy. If refractory to that, you can do TIPS. If EGD doesn't work, you should try EGD again. Some risk factors for rebleeding according to the Forest classification. Important things to know are class 1 is active bleed and class 2 are signs of recent bleed. So most likely to bleed is an active arterial bleed. Second most likely is a visible vessel that is not currently bleeding. And then third most likely is a venous bleed. Some indications to go to the OR are 4 units of transfusion with continued bleeding, shock despite transfusion, and continued bleed after you tried everything through the scope. If they're bleeding from a duodenal ulcer, you do a duodenotomy and you do a 3-point ligation of the GDA, making sure to catch that transverse pancreatic branch. If you have a perforation of a duodenal ulcer, you need to patch it, be that a Graham patch with the omentum or a Thal patch with a loop of Bowel or a falciparum ligament patch. For a gastric ulcer, perforation or bleeding, treatment for that is antrectomy and vagotomy with a Roux-en-Y reconstruction. If they do have a perforated ulcer, you need to get the entire thing out to send to pathology to rule out cancer. For any ulcer, bleeding, or perforation that you need to take to the OR, consider acid-reducing surgery at the same time if they've been on a PPI already or they have a history of H. pylori. And remember again that if you do a truncal vagotomy, you just denervated their pylorus and you need to do a pyloroplasty. For weight loss surgery, your requirements to get weight loss surgery is your BMI is over 40 or BMI over 35 with a weight-related comorbidity, be that OSA, hypertension, diabetes. They'll test you on which of the obesity related diseases doesn't improve with weight loss, which is PAD, but all the other ones do. They need to have failed lifestyle changes and medical weight loss. You need to be cleared by psychiatry, and they can't be abusing substances because people often trade a food addiction for another addiction. In terms of weight loss, Roux-en-Y has the most rapid weight loss over the sleeve, over the band and balloon. For terms of ABSITE, if they put on the band or balloon and they have the other 2 as options, usually the less invasive surgeries are not the correct answer. They don't have as predictable or as durable as a weight loss. You do want a 75 to 100 centimeter Roux-en-Y for the best metabolic effect. Something that comes up on the reviews, I haven't seen it on the ABSITE yet, but if you have a patient who had a jejunal ileal bypass in the past, this kills people and you need to convert them to Roux-en-Y if you see it. Some surgical complications, they love to test on these. First of all is leak at the staple line or anastomosis. Presenting sign will be tachycardia. They may or may not have a fever. You need to rule out a pulmonary embolism. That's the most common cause of death after a Roux-en-Y. If it's an early leak, you can take them to the OR for a washout, repair, or drain, or get them a feeding tube. And if it's late, you can send them to IR for a drain if their abdomen might be too hostile to re-enter. Internal hernias can happen even though you close those defects during the surgery, because once they lose weight everywhere else, they lose fat in the mesentery and their defects widen. They'll present with signs of bowel obstruction and a swirl sign on CT possibly. These people need to go to the OR to reduce their hernia and close their defect. You can get gastric volvulus, especially after a gastric sleeve. This will happen over the organoaxial axis. These people need to go to the OR to untwist their stomach and then pexy it to something so it doesn't twist in the future. You can develop a marginal ulcer at their GJ anastomosis. Your duodenum is no longer there to make alkaline mucus to neutralize the stomach acid. These people need to be on a PPI and told to stop smoking. Especially after a Billroth 2, you can develop alkaline reflux gastritis due to this afferent limb having bile directly connecting to the stomach. Some people try to get ahead of this by doing a brawn enterostomy, which is connecting the afferent efferent limb down here to avoid the reflux. But the important thing to know for this is that bile in the stomach is an inherent part of the Billroth, and you only treat this if they're having symptoms, which is bilious vomiting that is not relieved when they vomit. If it's refractory to cholestyramine or pro-motility agents, you can convert them to a Roux-en-Y with a long afferent limb to avoid bile reaching the stomach. They like to ask about dumping syndrome. Early on, dumping syndrome is due to fluid shifts. Later on, it's due to hyperinsulinemia, also because you don't have that duodenum to kind of slow everything down from moving from your stomach to the rest of your intestines. This is treated with small, frequent, low-carb meals, octreotide if refractory to that, and then if nothing else is working, you can convert them to a Roux-en-Y again. Blind loop syndrome is just functionally small intestinal bacteria overgrowth in an area with poor motility. That could be a diverticula, that could be a side-to-side bypass. It could be the afferent limb not emptying super well. A lot of pain, steatorrhea, B12 deficiency, malabsorption. The D-xylose test is the one they like to test on, so you know that you're treating intestinal bacterial overgrowth. Treat this with a low-fat diet and antibiotics, and you can shorten their afferent limb in order to avoid this. Afferent loop obstruction associated with Billroth 2s or Roux-en-Ys with a long afferent limb. They'll have right upper quadrant pain, non-bilious emesis, and then an episode of bilious emesis that relieves their pain. On scan, you'll see that their afferent limb is dilated and contrast doesn't reach it. You can try to dilate them to encourage emptying, or again, revise them to short afferent limb. Afferent loop obstruction is just a small bowel obstruction. You can try to balloon dilate this or do a surgical revision. Post-vagotomy diarrhea. This is a known complication. It's because their migratory motor complexes no longer get inhibited, so bile gets into their colon. They have diarrhea. Treat this with cholestyramine or low motil to slow things down. If medical treatment isn't working, you can reverse the orientation of some jejunum and plug it back in, and that slows things down. If you have duodenal stump blowout after performing something like a Roux-en-Y, that's another surgical emergency. You need to go to the OR, wash everything out, drain them, put a tube in the duodenum and drain that externally. People who get a gastric band, they like to ask about this. They can slip or erode. You'll see a phi angle, which is the angle between the spine and the band over 58 degrees, or it could flip anterior posteriorly, which will give you the O sign, which is in the picture. Immediately, you should deflate the cuff, and then later on, they may need surgery to get the band removed. Gastric masses, you'll see fundic polyps. If you see this, you're not worried. No malignancy potential, pretty much associated with prolonged PPI use. Hyperplastic and adenomatous polyps are associated with atrophic gastritis and H. pylori. The adenomatous ones are cancer. You should resect these during the EGD. Low-grade malt lymphomas, you can have these just due to H. pylori. Once you treat the H. pylori, that should resolve the lymphoma. If it's high grade, you may require chemorads in addition, which would be rituximab for the B-cell things. Gysts are sarcomas, so don't take lymph nodes when you remove these. They stain positive for c-KIT, aka CD117, and DOG1. Their pathology will show spindle cells. These are from the interstitial cells of Cajal. They're submucosal, so if you see something that looks like a gyst and then they biopsy and then it says it's nothing, then you're still concerned. You just think they didn't get it on their biopsy. Low risk GIST can be monitored. They should be resected if they're over 2 centimeters or causing symptoms of obstruction or early satiety. Moderate risk GIST should be resected, and high risks GIST should get adjuvant therapy with a tyrosine kinase inhibitor like imatinib. So this one's easy to remember: over 5 centimeters, over 5 mitoses per 50 high power fields, or if they're in the small bowel instead of the stomach, then you're very concerned. Surgery for this is just wedge resection with 1 centimeter surgical margins. On pathological margin is just no ink on the tumor, and you don't need nodes again. Gastric adenocarcinoma, risk factors: H. pylori, polyps, smoking, stomach surgery, smoked food, the blood type A, scary cancer. You want 5 to 6 centimeter margins for this in the body and antrum. If it's located in the body or antrum, you do a distal gastrectomy with a Billroth 2 versus Roux-en-Y gastrojejunostomy. If it's in the fundus or cardia, you need to take the whole stomach out and do an esophagojejunostomy. Same as esophagus, you get 15 nodes, 30 is better for staging. A D1 lymphadenectomy is the stomach nodes plus the greater and lesser mental nodes. A D2 lymphadenectomy is the above, plus you take the lymph nodes along the celiac axis. TNM, T staging for stomach is thankfully, you're able to remember it like the esophagus. T2 is the tumor invading the muscular layer. You need, same for esophagus, you need neoadjuvant therapy if it's T2 or N positive on your endoscopic ultrasound. If someone is unresectable, palliative surgery is still an option because you need your stomach to live and have quality of life. Proximal obstruction can get a stent. Distal obstruction, you can bypass it with a GJ. And if they're having bleeding or pain, consider RADS versus IR for embolization. Just random things to remember: the Krukenberg tumor are the stomach drop mets to the ovaries. Virchow's nodes are the stomach mets to the supraclavicular nerve. And the Sister Mary Joseph nodule is the umbilical node of mets. Okay, thoracic stuff. This is a pretty small portion of the ABSITE, so this is going to be quick. The azygos vein goes into the SVC on the right side. The thoracic duct crosses at T4 and 5, empties into the left IJ and subclavian vein junction. Phrenic is in the front, vagus is in the back. Right lung 3 lobes, left lung 2 lobes. Structures from anterior posterior, generally vein, artery, and bronchus. Mediastinal lymph nodes are in the single digits and are N2. Lung lymph nodes are in the double digits and N1 unless they're on the other lung or supraclavicular. Mediastinal masses: remove thymomas. If the thymus is large or they have myasthenia gravis, remove it. The most common mediastinal tumor is a neurogenic tumor or schwannoma in the posterior mediastinum. For PFTs, you need an FEV1 over 0.8 and a DLCO over 10 milliliters per minute per millimeters of mercury in order to qualify to have your lung resected. Empyema, remember Light's criteria: serum pleural fluid protein ratio to serum protein ratio over 0.5, LDH ratio over 0.6, or pleural LDH over 2 to 2/3 of the normal serum LDH. If they're getting on to week 3 to 4 of having an empyema, you'll need to do surgery to remove the rind so the lung can expand. Pneumothorax, chest tube, air leak over 7 days, non-re-expansion. They're a pilot or live in the mountains. They can't access a hospital. They only have 1 lung. Then you'll need to take them to the OR for VATS and mechanical paradesis. For hemothorax, or after chest tube, initial output over 1 to 1.5 liters, over 250 cc's per hour for 3 hours, over 2.5 liters in a day or unstable, you need to take them for VATS. And if they have a hemothorax that's not draining for over 2 days, you need to drain that also with surgery. Pylothorax, if you're doing your esophagectomy and you injure the thoracic duct, they'll have high lymphocytes and high triglycerides in the fluid. Above T5 to 6, it'll accumulate on the left side. Below that, it'll accumulate on the right side. And remember, you treat this with TPN, octreotide, and medium chain fatty acids. If it's refractory or high output, you can embolize or ligate. Lung cancer, they have to be operable, which their PFTs have to meet criteria, and they have to be resectable. If they're T4, invading structures, or over N1, which is the ipsilateral lung nodes, or they're M+, then they're unresectable lung cancer. Remember your paraneoplastic syndromes. Squamous cell carcinoma makes a PTH-related peptide. Small cell carcinoma makes ACTH or ADH. Pancoast tumors are those apical lung tumors that can press on your sympathetic chain, give you Horner syndrome, or your ulnar nerve and give you symptoms over there. Most common cause of SVC syndrome is lung cancer, and that needs emergent radiation. You are allowed to resect lung mets if they're from colon cancer, renal cell carcinoma, sarcomas, melanomas, ovarian, or endometrial cancer. if they're not associated with another systemic disease. Okay, questions at the end.
Awesome. Thank you, Mitchell. That is a very impressive review. That was awesome. I can't believe you're only like a junior resident. I definitely did not know all that stuff as a junior. That was very impressive. Okay, next is Dr. Jordan Brookheist. Hope I crushed that. He's an endocrine attending at University of Nebraska. He's going to give us our final session for the ABSITE review today. Endocrine is always a high yield, very important topic.
All right. Can you see this okay, Connie, and hear me okay? Great. Yeah, everyone loves endocrine surgery, especially in January. It's so funny. All my co-residents always became big endocrine fans and asked me lots of questions around that time. I'm coming to you from the University of Nebraska Medical Center. Thank you, Connie, Bev, and the SSAT for the opportunity. And thank you all for sticking around. Again, this will be online recorded, so feel free to come back to it. Getting into some high yield anatomy first, remember that there's superior and inferior thyroid arteries and veins. And then there's the middle thyroid vein as well as the thyroid ema artery in a minority of patients. Higher yield than that, though, are the two nerves that we care about most commonly in thyroid and parathyroid surgery. Remember that the external branch of the superior laryngeal nerve innervates the cricothyroid muscle. So the scenario you're going to be hearing about is you're taking down the upper pole of the thyroid, ligating those vessels, you injure a nerve, and the patient has loss of projection and pitch. They're asking about this nerve. They're not asking about the recurrent laryngeal nerve. So don't be fooled by that on the ABSITE. The other nerve, of course, is the recurrent laryngeal nerve, which innervates the remaining intrinsic muscles of the larynx. And injury to that, of course, paralyzes the ipsilateral vocal cord. So that's a big deal. And the sign is a breathy voice. Of course, if you injure both nerves, you're at risk of the patient needing a tracheostomy for airway protection. Don't forget about this idea of the nerve monitoring in the operating room, which many endocrine surgeons use. There's a lot of data on this topic, and there are several meta-analyses that don't support the idea that the nerve monitor particularly changes the risk of transient or permanent nerve injury. So occasionally that shows up in some questions. This is a placeholder just to let you know that you should also study all of the other head and neck nerves. There's a 1,000% chance of one of them being on the ABSITE and one of the deficits from some operation. And it may be endocrine, it may be head and neck, parotid, it may be breast. Make sure you come back to those and study them. When we think about thyroid cancer, the two compartments we talk about most are the central neck, which is level 6, between the carotids up to the hyoid and down to the innominate, and then the lateral neck, which is levels 2, 3, and 4. So there are other, of course, stations, but those are the most relevant ones to thyroid cancer. Then getting into the meat of thyroid nodules, which is a high yield topic, of course. Most of these are found incidentally, but can also be found on physical exam or by compressive symptoms reported by the patient. So you're going to ask about thyroid function, compressive symptoms, if they've had neck radiation, which is a risk factor for thyroid cancer. And then, of course, if they've had neck surgery or if they have a family history of thyroid cancer. Make sure you palpate the cervical nodes as well as the thyroid for nodules on your physical exam. And then I think the biggest fork in the road when it comes to thyroid nodules, especially as you're thinking about this for test taking, is what the TSH is. So if the TSH is normal, that you can assume the patient has normal thyroid function, assuming they're not already on thyroid hormone replacement. And so then you're going to go down this path of trying to figure out if the patient is at risk of cancer. Keep in mind, though, if they're describing a medullary thyroid cancer specifically, you have evidence of that on a biopsy, perhaps. Remember that you should also check CEA and calcitonin, which are the tumor markers for that cancer. Ultrasound is going to be your imaging of choice for thyroid nodules. And remember that there are ways in which we stratify these nodules based on the imaging criteria. This is the American College of Radiology TI-RAD system, which you're all familiar with. There's 5 characteristics of the nodule. And then you sort of add up the points and put them in one of these categories, decide if they should get an FNA based on the total points. So you can try to memorize this, or you can kind of just put it together. And if you look at this closely after this, you'll realize that anything that's cystic or described as spongiform is going to be benign. And so you're almost never going to need to biopsy those or do surgery on those. Then if you hear things like solid, hypoechoic, taller than wide, extrathyroidal extension, and microcalcs, those are all the sort of buzzwords for a high-risk lesion. And so if you're hearing a lot of those and it's greater than 1 centimeter, you're probably in TI-RADS 5 and you should probably biopsy it. And then, take note of TI-RADS 3, which is greater than 2.5 centimeters, you biopsy. So that's another quick and easy thing, that if it's greater than 2.5 centimeters and not a cyst or spongiform, you're probably going to biopsy it. Once you biopsy a thyroid nodule, your approach again is a FNA, a fine needle aspiration. So you're getting cytology alone, not architecture. So that puts you in one of 6 Bethesda categories. So remember that Bethesda 1 is non-diagnostic. Bethesda 2 is the benign category, and then it ranges all the way up to malignant. And so what you do about this is shown here. So Bethesda 1, you're no better off than you were before. You need to repeat the biopsy. Bethesda 2, it's benign, and so you can either use surveillance ultrasound, or if the patient's symptomatic, you can offer them surgery. If you're in AUS or follicular neoplasm, Bethesda 3 and 4, these are sort of the indeterminate categories. So you have options here. Most places now are offering molecular testing for these, and the details of that are not so high yield, but just know that that's something we use to further risk stratify and look for mutations in the nodule that are associated with thyroid cancer. You can also offer them a repeat biopsy if molecular testing is not available. And then always remember, you can go straight to diagnostic lobectomy. I would be reluctant to pursue that on the ABSITE. Make sure you've checked for your other options and further risk stratifying before you go to surgery in those, but it is an option. And then Bethesda 5 and 6, you're going to go to surgery. Keep in mind that if you have a papillary thyroid cancer that's less than 1 centimeter, so a B6, where they say it's papillary thyroid cancer, those are candidates for active surveillance with ultrasound. So just to quickly summarize the subtypes of thyroid cancer, remember you have your differentiated types, which are the most common. Papillary spreads lymphatically, and remember the buzzword of orphan antinuclei on cytology. Follicular spreads hematogenously. And then you have this other category of poorly differentiated. And the way the pathologist sort of makes that distinction is not so high yield, but just know that that's a category that's more aggressive. Remember, medullary arises from the parafollicular C cells. So again, you're going to check CEA and calcitonin, and do not forget about MEN. They're going to try to trick you into going to thyroidectomy for a medullary thyroid cancer, but be sure you've considered and checked for a PHEO in those cases. And lastly, anaplastic thyroid cancer is a very aggressive subtype. Oftentimes, those are palliative and multidisciplinary. So if it's resectable, you can and should do a total thyroidectomy, but oftentimes it isn't. When you're deciding about what surgical approach to do for these well-differentiated papillary and follicular subtypes, a lot of the characteristics are shown here. But if it's a cancer that's greater than 4 centimeters, or they have nodes or extrathyroidal extension, bilateral lesions, metastasis, go for the total thyroidectomy. If they don't have those features, you can consider lobectomy. And then remember that oftentimes your biopsy is not definitive for malignancy upfront. So if your final pathology comes back that has some of these features, or you see something like tall cell papillary thyroid cancer or hobnail variant, those types of things are going to be reasons you're going to go for the completion thyroidectomy to allow for radioactive iodine. And remember that the decision about radioactive iodine is a nuanced decision with an endocrinologist based on the ATA risk stratification system. And so you can look that up on your own. I think a lot of the details in that are beyond the scope of what's high yield for you. But know that if you're seeing these high risk things like extrathyroidal extension, metastasis, nodal disease, you're probably going to be considering it. So then when you're thinking about what operation to do, again, with differentiated, you're thinking about lobectomy versus total. You're going to add in a neck dissection for any positive nodes. And so if you know about it ahead of time, you would biopsy it and confirm that it's a metastasis. So if it's in the central neck, you're going to do a total thyroid with central neck dissection. And if it's in the lateral neck, you're going to do a total thyroidectomy with central neck dissection and ipsilateral lateral neck dissection. Same approach for poorly differentiated, except no lobectomies here, always total thyroidectomy. For medullary, you're going to reach for the total thyroidectomy with central neck dissection as a baseline for all medullary on the ABSITE. You're going to add in an ipsilateral lateral neck dissection for positive nodes. And do not try to give these patients radioactive iodine. Again, it doesn't arise from the follicular cells. It's not going to help. And lastly, we talked about anaplastic thyroid cancer being multidisciplinary. Don't forget about thyroid lymphoma. It's classically a patient with Hashimoto's who has a rapidly expanding goiter. They'll give you some biopsy information about abnormal lymphocytes in the biopsy. And what they want you to think about is lymphoma because the treatment is not surgery. So keep that in mind. Watch out for that pitfall and don't try to operate on those patients. Then quickly getting into hyperthyroidism, we talked about TSH being sort of the fork in the road for thyroid nodules. Remember, the symptoms are shown here. The TSH is going to be suppressed in this case, and you're going to find elevations in T3 and T4. You're going to check a TSH receptor antibody, which is elevated in Graves' disease. And then your ultrasound is still going to be your friend looking for nodules to help you figure out what the source of the hyperthyroidism. And then RAI can help you delineate these. So in Graves' disease, the RAI uptake scan is going to be diffuse uptake throughout the thyroid, whereas the toxic nodule and toxic multinodular goiter are going to be uptake within those nodules. What you do about it is you start medically, so with PTU or methimazole, and remember the commonly tested side effects of those medications, including agranulocytosis and hepatotoxicity. Total thyroidectomy in these patients is a great option. It's the most definitive. It's indicated in large compressive goiters or failure of medical management. Remember, though, that a toxic nodule in a toxic nodule, a lobe is appropriate because you're taking out the thing that's causing the problem, assuming again that they don't have some problem on the other side, like another suspicious nodule. Radioactive iodine is also appropriate in these cases with the exception of pregnancy and thyroid eye disease. So those cases are going to push you more towards the other categories. Remember that patients of childbearing age should always consider total thyroidectomy to take the Graves' disease, especially, or the hyperthyroidism off the table for future pregnancy. Take a second on your own to review these other diagnoses that come up on the ABSITE. They're a little bit more fringe, but they do like to throw those in there once in a while. So make sure you review those. Getting into parathyroid. So remember that the superior parathyroids come from the branchial pouch 4 and the inferior from 3. The superior glands are posterior and lateral to the recurrent laryngeal nerve, and the inferior are anterior and medial. The arterial supply is from the inferior thyroid artery. So the bread and butter of this is primary hyperparathyroidism. That's the most likely thing to be tested on the ABSITE. It's the most common cause of hypercalcemia, and the diagnosis is biochemical, so it's from the labs. You want to see an elevated PTH and an elevated calcium. And remember that normal isn't normal in endocrine, so there's some nuance to the interpretation, but that's generally what you're looking for. You'll see oftentimes in the references, especially the addition of 24-hour urinary calcium, which is not required for the diagnosis, but can be helpful, especially if you're worried about familial hypocalciuric hypercalcemia. Always a mouthful, but remember it's the calcium to creatinine ratio of less than 0.01, which is going to be suggestive of FHH and going to result in a referral to genetics. And you're not going to operate on that patient because it's not going to help them. You can also check a vitamin D to rule out secondary disease from deficiency. And remember that with calcium, we use albumin to correct the calcium because the component you care about is the free calcium. Or alternatively, you can check an iCal, which it checks for that fraction. You're going to ask the patients about subjective symptoms of hypercalcemia. You've all heard these 1,000 times. And then you're going to look through their history and ask them about issues that have arisen that may be complications of their parathyroid disease, including bone disease, fractures, kidney stones, and chronic kidney disease. So if the patient doesn't have symptoms or complications, then you go to these guidelines, which tell you when to operate for asymptomatic patients. So I won't go through them one by one, but we'll point out that a calcium one above the upper limit of normal, which you don't know what the upper limit of normal necessarily is on the ABSITE, that's based on your local lab. But if they give you that, that's a reason to operate. If they're less than 50 years old, that's another easy reason to operate. And then make sure you review the rest of these as well. Briefly, imaging localization for parathyroid disease is not required, but is helpful. So many surgeons will just go ahead and do a bilateral exploration up front without any imaging at all. If you're going to get imaging, I think ultrasound makes a lot of sense because you can localize parathyroids and also check for concomitant thyroid nodules. And again, if you find one, you're going to work it up just like we talked about before you get to the operating room and know what to do about it at this same time as the parathyroidectomy. Other commonly used tests for localization are the 4D CT and the Sesta MIBI scan. Remember, there's two approaches. One is the focused approach where you go after your targeted lesion seen on the imaging. And then the other is a bilateral exploration. So you're going to do bilateral if you don't use imaging localization, or if the imaging doesn't show just a single candidate or a unilateral candidate or candidates. Remember that IOPTH, intraoperative PTH, is used to help guide the completion of the operation. And you want to see a drop 50% and into the normal range as the indication that you've cured the patient surgically. That's known as the Miami criterion. Briefly, secondary and tertiary. So secondary is most commonly due to chronic kidney disease, but again, remember vitamin D deficiency, which we talked about, and other etiologies. In renal secondary, you're going to have initially a low calcium and high phosphorus, consistent with kidney disease. Eventually, they can have refractory elevations in PTH, which results in difficulty controlling their calcium. So they're going to be treated medically initially. And surgery is reserved for patients who fail medical management or who have complications such as calciphylaxis. You'll see in your resources, former recommendations said PTH greater than 9 times the upper limit of normal was an indication for an operation. That has changed and is not so much the case anymore, but know that that's out there. And then tertiary is where the patient has had a kidney transplant and then has persistent disease following that. The biochemistry mimics that of primary hyperparathyroidism, and then the treatment is parathyroidectomy. So your operations here are subtotal parathyroidectomy, which is 3.5 glands, or total thyroidectomy with parathyroid autotransplant. And the reason for that is because the disease affects all 4 glands. So you need to do something that's going to, limit the amount of parathyroid tissue they have remaining through one of those approaches. And finally, adrenal. High-yield anatomy is that, of course, as you know, the right adrenal gland drains via the adrenal vein into the IVC, and on the left side, the adrenal vein drains into the left renal vein. Remember that the adrenal is broken down into the medulla and cortex, and then the cortex is further subdivided into the GFR layers. And each of those is responsible for the production of a specific hormone. So as you're thinking about this, this is one way to kind of remember what you need to work up to rule out functional adrenal nodules. So the most high yield topic related to adrenal is the incidentaloma. It's found on commonly and is our most common adrenal referral because these patients are getting scans for many other reasons. But when you see these patients, you want to ask about the symptoms of functional adrenal nodules. Ask about symptoms of Cushing's disease or signs. Ask about medically refractory hypertension, which is suggestive of hyperaldosteronism. Ask about personal history of cancer, because you always want to consider metastasis to the adrenal gland in your differential diagnosis. And then ask about those episodic headaches, hypertension, palpitations that may be suggestive of a PHIO. Your imaging of choice here is the adrenal protocol CT, which is thin cuts, multi-phase. The things they're going to tell you, the buzzwords are the Hounsfield units. So less than 10 is consistent with a lipid-rich adenoma. Greater than 10 is indeterminate. There are adenomas that can be lipid poor. So that doesn't necessarily mean it's not benign, but you're sort of in this indeterminate category. And then remember that there's this sort of rough line in the sand at 4 centimeters based on previous studies that have shown that the risk of malignancy is higher in that size. So you're not going to use that alone, but in conjunction with the Hounsfield units and the overall descriptors, a heterogeneous large tumor that's dense, greater than 10 centimeters, you're starting to think that they're probably leading you towards ACC. On the ABSITE and in real life, we almost never biopsy adrenal lesions, but certainly if you are considering that at all, and I would argue you almost shouldn't for the ABSITE, but if you are, be sure you've ruled out a pheochromocytoma biochemically before you do that. All right, so quickly, the functional workup is complicated, and if you look in resources, you'll find hundreds of ways to do this, but this is, I think, one of the more straightforward approaches, which is to check plasma metanephrines and normetanephrines. Check your aldosterone, your renin or renin activity, and your potassium. And you'll see this aldosterone to renin ratio in your review text. The most commonly reported ratio is greater than 20, but it depends on what assay you use. And so if you find other sources, they'll list many different versions of this. I think that's less testable, but that is out there, just so you know. And then adrenal vein sampling, the indications for this are evolving. Historically, it was used for patients of higher age, so greater than 45 or 35, because of this idea that those patients are more likely to develop benign non-functional nodules that may not be the source of their aldosterone. So currently, many guidelines and many surgeons will get ABS in more aggressively than that. So keep that in mind as you approach the ABSITE. Definitely get it if the patient is of a higher age. And then for cortisol, I think the dexamethasone suppression test is a nice first-line test. You give them dexamethasone, you test ACTH, dexamethasone, and cortisol. And then if you have a suppressed ACTH with a cortisol above 1.8, that's consistent with mild autonomous cortisol secretion. And then a Cushing's diagnosis requires at least a second abnormal cortisol test plus the clinical findings. And finally, you want to look at your DHEAS, which is a specific androgen produced by the adrenal. So if that's elevated, especially if you have some of those other imaging characteristics, that's going to put you down the road of thinking this may be an ACC. For the ABSITE, I would approach an ACC through an open approach, although know that is also evolving. And so many times you'll see surgeons that are doing minimally invasive approaches to that as well. For ACC, you're going to do resection of all involved structures en bloc. And then if there's tumor thrombus in the IVC, you're going to take that out as well. Don't forget for Phyllodes to alpha block first, then beta block leading up to surgery. For hypercortisolism, remember that you need to replace their glucocorticoids after surgery or test them for adrenal insufficiency. And then lastly, just to briefly mention the picture of adrenal insufficiency, you're all aware of it, but be mindful of that on the ABSITE. If they're giving you this type of picture, especially after adrenalectomy, and they have cardiovascular collapse or hemodynamic instability, you're going to reach for your stress dose steroids. I won't go through this, but friendly reminder, know this front to back, the MEN syndromes, and don't be tricked on the ABSITE. Thank you again for the opportunity. Look forward to your questions.
Awesome. Thank you so much, Jordan. Man, that was great. It's like expert knowledge on endocrine, just like super, super high yields for ABSITE. We still have about, let's see, 35-ish people on the call. If you have any questions, feel free to put them in the Q&A. I definitely want to thank the panelists for giving their time to put together this presentation today. This is like one of the best ones we've had. This was really great, engaging conversation. You guys put a lot of work into this. And this will be on the website. Tell your friends, tell your mom. We'll have the PDFs of the PowerPoints and the videos up on the website, so you can watch it whenever you want. Definitely a great framework to go off of, and then start building on details afterwards. But if there aren't any questions, we're going to head and end the meeting. Thank you, Bev, who is the one that's responsible for putting together all of this and being the person that makes SSAT function the way it does. For those of you who are not yet members of SSAT, highly recommend joining. It's like $20 or something. But it's a really great opportunity to get involved, especially as a resident. I'm on the resident and fellows committee. It's a great time. We do stuff like this all the time. So thank you, Mackenzie, Hillary, Mitchell, Jordan. This is awesome. Thank you guys for being such an all-star crew. All right. If there's no questions, this video will live forever on the internet.